And we're fortunate today to have two people talking to us. I'll introduce Christina, and I want to read her introduction so I don't forget anything. Christina Goodwin is the California and Hawaii's state manager for Compassion and Choices, an organization dedicated to improving care and expanding options at the end of life. Prior to this position, she worked to pass the medical aid in dying laws across the country and was an integral member of the campaign to pass California's end-of-life Option Act. She has been at Compassion Choices you've been at Compassion Choices since 2008. Christina has worked in the nonprofit field for 20 years and previously worked with the Tuolumne River Trust and the Santa Rosa Symphony. She lives in Woodacre, California, Marin County, with her husband, 3 kids, and a dog. In her free time, she enjoys baking, knitting, and reading. How much free time do you have?
No weekends.
And Ralph is our village member who's going to share his experience. So after they give their talk, if you have any questions, you can actually write them down and I'll take them, or you can, raise your hand. But we have a lot of time for questions and answers. So first, Ralph, will you introduce yourself?
I'll be pleased to. Hello, everybody. I know quite a few people here, so I wanted to thank you all for being here. Okay. Well, I'm here to tell the story of my wife's decision to end her life legally with the End-of-Life Option Act that California passed, and my experience of supporting her in the process, and how it has been and is all the way till now for me. So I also want to mention that Avenidas and the village has been really an important support to me personally, and particularly Paula Wolfson's caregiver support group, which I've been a member of for more than 4 years, and continue to go to, even though obviously Susan has died. And there are several of the members of that group who are still there, whose spouses have died. It's been a wonderful, close-knit support group. So Susan and I were married 20 years ago. It was a second marriage for both of us. And we each have 2 children, and our children are all married and have grandchildren. So between us, we have quite a few grandchildren, even in Sue's case, some great-grandchildren. We also have, she has a sister, I have a brother, and fortunately, all of our family was supportive in Susan's choice of ending her life. In one case, I'm sure that her sister would not choose that herself, but her family was understanding and accepting. And that's really important, that the families know what is intended and support it, which they did. In 2011, that's 8 years ago, Sue was diagnosed with Parkinson's disease, and for the first several years was able to function pretty normally. We traveled, went to symphonies, belonged to theater works, and so forth. But in 2014, because of symptoms, she was diagnosed with what is called multiple system atrophy, which affects the autonomic nervous system and has a number of symptoms, and is a fatal disease with a life expectancy at the time was from 4 to as many as 10 years. And it affects all of the automatic functions that the body has, like swallowing, blood pressure, speech, writing. So she, over the course of the next years, gradually got to the point, and I should say, in preparation to give a talk, I decided I would go through my 38 pages of notes that I made from 2011 until she died. And I'm sorry that I did, because I revisited all the downward events, all the bad days, frankly, that occurred, and it was very depressing to revisit that. So I decided, after writing a lengthy list, that I would not burden you with that. So without going into any detail about it, I'll just say that by 2017, she was, because she did not have dementia, she had looked up on her computer all the end stage of the disease, which was dreadful, and had begun to consider how to avoid the last years of that disease, and had gotten interested in compassion and choices, had told her family that she didn't want to live beyond into that period of time. She was losing many of the abilities and having trouble swallowing, etc. So I won't go into the details of that. In 2018, she was near the point of not being able to go down our exterior stairs in the condo that we lived in. So we began looking into facilities, and I chose a board and care type of facility because, although she didn't have dementia, the other facilities that provided the kind of care she would have needed, the kind of care she would have needed were for people with severe dementia. And board and care facilities seemed like they would be the better choice. So in 2018, in January, she moved into a small facility in Sunnyvale, and for the next year and 3 months, I went every day for a number of hours to make sure that her treatment was good. And frankly, no matter where you choose to go, as I'm sure some of you know, it would be better to be at home with caregiver full time, but that isn't always financially practical. And I wasn't physically able to continue some of the care that she needed, even though we had caregivers for a considerable number of hours. So her decline continued, and fortunately she had a physician who she'd had for 30 years, who was agreeable to approving death with dignity, assisted suicide. And Sue was seeing at one time neurologists at both the Parkinson's Institute and Stanford. We eventually stuck with just the Stanford neurologists in the movement disorder clinic that's next to the old Hoover hospital, and who was wonderful. I'm not going to mention all the physicians' names. Personally, if anybody has a need to know, you can ask me. In fact, I hope I have a chance to answer any question whatsoever that anybody has. I'd be happy to do that later, or individually after our group at some point. In any event, so let's see. we the board and care facility was challenging because there was no social interaction for her, and that's part of why I was there so much of the time. And her family came to visit occasionally, but came the point at which, because her swallowing was getting iffy, and she realized that she would have to make a decision to go ahead with the end of her life. So we, with my help getting the paperwork that was necessary, she filled out first one and then a second request to her doctors, both of whom agreed and signed it. Then the question was whether she would be able to, once we obtained the medicine, whether she would be able to do it at the facility. Well, the facility owner, although I asked, wouldn't answer the question. And so time was getting closer. I should mention also that we had decided to make a brain donation, so I'd made arrangements for that when the time came, and the mortuary and all of that. I know I'm leaving out things, so I hope people will ask questions when after Christina has talked. In any event, let's see, what have I know I've missed some things. Let's see what. So in March, the early March of last year, when I finally pressured the facility for an answer, and I had not discussed with the staff our Susan intention, because the caregivers there were all religious, and the issue really was a matter for the owner of the place, not the individual caregivers, who are truly caring people, as were, I should say, all the caregivers we had at home. Some wonderful, dedicated people, underpaid though they are from facilities. Finally, under pressure, the owner of the place said, no, we won't allow Sue to end her life here. So the social worker and we had had hospice for the last 4 months, or Sue had. So the social worker was the only one who was dedicated to Sue's desires, and she arranged a move back to our condo with an ambulance. She moved the hospital bed back, arranged to have that moved back. All of this occurred like a whirlwind in the course of 24 hours. Even got a temporary caregiver to come and help. Now, in the meantime, Sue's doctor, who had never been through this before and had contacted Campassion Choices and had been educated about how to proceed with the paperwork and educated about how to deal with the medication that would end Sue's life, was a complete novice in this process that had occurred that went on earlier. She had trouble finding a pharmacy that would take care of this. And I've talked to others who ended up with a large number of pills, which a would-be person couldn't possibly swallow. So these pills need to be ground up into, and then mixed with water. So I was insisting that to Sue's physician that she find a place where they would grind it up. I could mix them. Anyway, so the pharmacy she found was actually at Stanford in the Hoover Hospital, and it was questionable right down to the almost last minute. Finally, they said, yes, you can pick it up. So I talked to the pharmacist who handed me a little glass bottle with the ground up medicine. I said, what can you tell me about what will happen? And he said, well, I haven't done this. I don't know, but I think it takes like 45 minutes for the person to die. And that I really don't know any more than that. So off I went home. By then, Sue's daughter had come up from San Diego. And Sue was in a hospital bed at home with the caregiver helping, and the social worker was there who helped. So we all had dinner. The next morning was the time that this was to happen. Let's see, Sue was determined, so I mixed the cocktail. I was concerned, of course, would Sue be able to do this all by herself? And I forget the exact number of ounces that it ended up being, and she was to drink the entire cocktail. And it was to be just me and Sue in the room, which we did. We said goodbye. She had also talked to a whole group of her friends. Her son and his wife had visited 2 days before. Her sister and her husband had visited just before she moved back to the house. So she had had a chance to say goodbye to a large number of people. Sue and she was sitting up in the hospital bed. I gave her the glass with the entire drink in it, kissed her. It was unbelievable event. She, on her own, drank the entire thing down, and then her daughter came into the room. Within 4 or 5 minutes, she was unconscious. However, without going into the details, it didn't take 45 minutes for her to die. It took 10 hours. And during those 10 hours, although she was unconscious, and I'm sure didn't feel anything, there were spasms and blood and temperature rises and falls, and it was agonizing for her daughter and me. And we had no idea what to expect. I called several people who I thought would have knowledge about what was going on and what to expect. And as time went by, the nurse came from hospice. She didn't want to be there when Sue was drinking the potion. I found out that it was not unusual for it to take a long time. Subsequently, I found out from Robin Riddle, who facilitated the brain donation. She runs an organization called Brain Support Network, and I've known for years, very good organization. She knew from the cocktail that at that time was used in Oregon was stronger. And these medicines have been changing over time. So I don't know what it is today, but I'm probably different today. Anyway, let's see. So when Sue died, because we were doing a brain donation, we had already gotten ice bags and so forth together, packed those around her head, had arranged for an ambulance to come and pick up her body and take it to the mortuary so that that procedure could occur. Let's see. It was a dreadful experience, and I've had, as I'm sure any of you have had, all kinds of feelings when a loved one has died. I really don't think, in a way, it's any different. Whether in my case I assisted my wife in suicide, or whether a loved one has died on their own, I really think that's probably no different in a way. But I don't know. So I think that's enough for me to say. I think I've conveyed the experience that I had. I miss Sue terribly. I still do, and I always will. Anyway.
Thank you.
And I do want to answer any questions about what happened and what I feel about the process. Thanks.
Thank you. Yeah, thank you. Thanks, Ralph. Hello, can you guys hear me okay? Okay. Thank you so much, Ralph. It's a tough act to follow for sure. And just a couple of things that come to mind when you're talking about meeting with your doctor or ending up in a facility that is caring for your wife, and just how important it is to integrate medical aid in dying into the standard medical care, so that we don't have to go to doctors, that will charge us $5,000 for a consultation. Being able to go to our primary care doctor who knows us and will support us in our wishes if that's what we want. And then the other thing is we try to veer away from the word suicide. A person that is suicidal, they don't see any way out. They may not be terminally ill, whereas somebody with a terminal illness who wants to use aid in dying, they want to live, but their disease is killing them. So we try to say aid in dying instead. So I I rely on my notes. I'm sorry. This is a new position for me, and like Kayleen said, I did a lot of work working to pass the law, and was on the team that passed the End of Life Option Act. So I'm really happy to be back working in California and to be doing our Access campaign and to do education so that the general community, the public, medical professionals, they know about this. And so when we go to the pharmacy, they'll be able to give us the information that we need because the law is so new. So I'm just going to skip this page, see how to do this. So I'm here today because stories matter. And I do know, I think most of you have been coming to presentations on the End of Life Option Act, so you know the nuts and bolts of it. I'm just going to do kind of a brief overview, and then I'll get into the, the more nitty gritty and the statistics. We can talk about the medication. I think the medication, when Sue took it, is different today. They have found, doctors have found a better combination of medicines that will put the person to sleep within 5 to 10 minutes. And what we're finding is within 2 hours, they have died in their sleep. And there hasn't been any, instance of abuse, coercion, or it not working since using this medication. So we can get into that. But I'm here today because, I've had good deaths in my family and bad deaths. My terminally ill grandmother, she went into hospice. She did not have aid in dying in her state of Delaware. So she was terminally ill, but the hospice facility, the people that were helping her said she could stop eating and drinking, and they were able to manage her pain and discomfort through that process. And I think it helped our family feel better about her passing, knowing that she wasn't in discomfort and didn't have to prolong it for any longer than she needed to. Whereas I've had bad deaths in my family, where my terminally ill grandfather, we did not have aid in dying in California then, and he committed suicide because he didn't see another way out. So it's so important to talk to our family about death and to talk to our doctors about it so that they know it's an option if we ever choose to do it. Sorry. Campassion and Choices is the oldest, largest, and most active nonprofit organization dedicated to improving care and expanding options at the end of life. I need one more arm. So our vision is a society that affirms life and accepts the inevitability of death, embraces expanded options for compassionate dying, and empowers everyone to choose end-of-life care that reflects their values, priorities, and beliefs. Can you see okay? Okay, cool. I feel like I'm talking to your back. Sorry. So we advocate to move beyond patient-centered care to patient-directed care, where the patient is in charge of making their own healthcare decisions. Also, that we should be fully informed and supported by our doctors and medical team on the full range of end-of-life options. So I think you guys have gone through this before, but Campassion and Choices believes we should have the full access to all end-of-life options, including pursuing life-sustaining treatment. If people want to get as much treatment as possible and end up in the ICU, we're totally for that. Or discontinuing or refusing medical treatment. Hospice, voluntarily stopping eating and drinking, palliative sedation, and medical aid in dying. And we also want people, no matter which option they choose, that they enter hospice as soon as possible. Okay. So, this past October, the California Healthcare Foundation launched a comprehensive study of serious illnesses and end-of-life care. The report revealed that 3 in every 4 Californians, or 75%, support the End-of-Life Option Act, giving terminally ill adults the option to get the prescription from their doctor. And all demographics support this option, including 68% Latino and 70% African American. In fact, 65% of those who are 150% or more below the federal poverty level also support the End-of-Life Option Act. The majority of people said if they had an advanced illness, they would prefer dying a natural death and making no attempts to prolong their life. Other interesting facts from the survey include that only 20% of Californians with a serious illness have had a conversation with their doctor about their desire to receive medical treatment at the end of their life. Only 20%, although 80% say they want to be able to talk to their doctor about it. In addition, 9 out of 10 Californians want palliative care if they're seriously ill, and only 4 out of 10 do receive this care. So as you know, the California End-of-Life Option Act went into effect on June 9th, 2016, and Governor Jerry Brown signed the bill, and in his signing statement he said, "I do not know what I would do if I were dying in prolonged and excruciating pain. I am certain, however, it would be a comfort to be able to consider the options afforded by this bill, and I wouldn't deny that right to others." So, the End-of-Life Option Act requires that the physician must inform the person about all of their end-of-life care options. Other requirements include making 2 verbal requests, 15 days apart, and 1 written request. And the written request form can be found on the Campassion and Choices website. 2 physicians must confirm eligibility and confirm the terminal disease. And 2 witnesses must attest to the voluntary nature of the individual's request, and only 1 can be a relative. And then within 48 hours prior to ingestion, the patient must reaffirm his or her intention to use the medication and that they understand what it will do. So we're encouraged to see that the state's data is reflecting normalization, that people are getting the care that they want from their own doctors. We're continuing to work so that every terminally ill Californian has equal access to all end-of-life care options, including hospice, pain control, palliative care, and medical aid in dying. We are in the ramp-up phase of implementation, and each year, access to the law will get better as healthcare consumers become more empowered, health systems improve their processes, and doctors become more educated and comfortable with the practice. So we estimate it takes 3 to 5 years for a state to become accessible, and California is off to a good start. As mandated by the law, the California Department of Public Health provides a yearly report. In 2018, 180 unique physicians prescribed medical aid in dying, which is actually 25% down from 2017. We don't get the 2019 data till July. But the reason for this discrepancy is the temporary validation of the law due to a court case and the ripple effects it had. Another thing, there was a frequent shortage of the medication that was being used at that time, Seconal, and it's no longer being used. Seconal was the one where you would get a lot of pills and then you would open them up. I forget how many it was, hundreds of pills, open them up into a powder. Now you get a powder from the pharmacy. And you get it from a compounding pharmacy. So looking back at the numbers since the law was first authorized in June 2016, we know that 86.7% of patients who use medical aid in dying were receiving hospice and or palliative care. The average age in California is 74 years old. 27.2% of patients who qualified for medical aid in dying don't ever use the medication. This graph, it shows the majority of people who qualify for the End of Life Option Act have cancer, followed by neurological disorders like ALS, Parkinson's, Huntington's, and then followed by cardiovascular diseases. This next graph, it shows the types of cancer people have who apply for the End of Life Option Act, and this data comes from 2018. So overall data from all authorized states show that fewer than 1% of people obtain a prescription for medical aid in dying, and most are over age 65 and have a diagnosis of cancer. 90% are enrolled in hospice, and like I said, a third of them don't use it. Not one instance of abuse in combined 40 years across all the states. And then medical aid in dying does lead to improved hospice care, palliative training, and conversations between doctors and patients.
What's the denominator on the first? Fewer than 1% of the people, of which people obtain a prescription?
Just across the entire U.S. population. It's a small percentage. A small percentage of people actually get medical aid in dying medication.
So including people of all ages?
I don't know. I'd have to go back and look. I would say over 18 because you do have to be over 18 to qualify. Yeah, we can figure that out. Thank you for pointing that out. So in Oregon, where a similar medical aid in dying law has been in effect since 1997, this graph shows the number of prescriptions for the Death with Dignity Act compared to the number of deaths from taking the medication. The green line is the prescriptions written, and then the purple line is people taking the medication. Around 2014, when you start to see it going up a little bit, we began our access campaign in Oregon. We weren't doing one for a very long time. It was all about trying to pass laws, trying to keep laws in place. So now we do our access campaign, and you'll see that the line, the green line, more people became aware about the law, more doctors were writing prescriptions, and then the other factor is that 2014 is when Brittany Maynard moved from California up to Oregon, and she brought it to the national headlines.
Can you even do this without hospice?
You can. Yeah, you don't have to be on hospice to qualify. Yeah.
I'm just talking about practical, what's involved.
It's hard, but you can do it.
As far as taking the medication,
Well,
can you do it without hospice?
yeah, I know you can.
Yeah,
but
yeah.
Practically, is it doable, or would it be easier if you were on hospice?
I think for the most part, we always recommend that people are on hospice when they do that, so they get that extra care. And hopefully you can find we'll talk a little bit about what you can do, but you can talk to your doctor to make sure they support your wishes. You can find a hospice that would be supportive of your wishes, so that you don't have to leave a facility to go home or to go to a hotel like some people have to do. So based on the Oregon data, this is why people choose medical aid in dying. 90% losing autonomy, less able to engage in activities making life enjoyable, loss of dignity, losing control of bodily functions, burden on family, friends, caregivers, and then lower inadequate pain control or concern about it, and then the 3.9% financial implications of treatment. Okay, so I'm gonna have to read this one. This is a picture of Jane Roberts and her 83-year-old husband, Jay. He was a retired university professor that used the law on March 15th, 2019. In mid-January, Jane knew something was wrong because Jay seemed a little disoriented, not knowing quite where he was or making mistakes like trying to sit in a chair that was turned the wrong way. Finally, after an episode while out with Jane's sister and brother-in-law, Jane called his primary care physician, who directed them to take Jay to the emergency room. Once at the hospital, an MRI was performed, and they found signs of a brain tumor. A biopsy was scheduled for January 30th to determine the diagnosis, glioblastoma on the right side of his brain. The next day, Jay was moved to a skilled nursing facility. Jay and Jane met with a consulting oncologist who suggested what could be done to slow things down: radiation, chemotherapy, or surgery. Jay felt he had lived a good life and he did not want to prolong his dying process. His family was 100% on board with his decision to utilize the law, and it was an option his family had supported even before the law was passed in California. The oncologist stated he was unwilling to prescribe the medication due to his religious beliefs. He did recommend another physician in the same medical system who did cooperate. On February 21st, Jay met with that doctor and started the process with his first official request for medical aid in dying. Jay's second appointment was on March 13th, where the physician asked him if he wanted to rescind or proceed. Jay stated very firmly, "I want to proceed." Jane shared, Jay absolutely never wavered from the moment he learned of the diagnosis. In fact, every day before the second appointment, he would beg, "Just do it." We kept having to explain that he had to wait. This was the most awful part of the whole process. 2 days later, on the morning of March 15th, the package containing the medication arrived. It can be shipped. Jay was ready to take the medication, and he did so within the hour of its arrival. Jane and their daughter, Annie, mixed the medication with apple juice, and Annie asked Jay, "Dad, is this what you want?" To which Jay replied, "By all means." He drank out of a straw, and soon he was gone. It was utterly peaceful, his wife expressed. Jay accepted death with perfect calmness. Annie and Jane were at peace with what he wanted, happy that they were able to find a doctor willing to prescribe under the law and that they could be with him at the end. So, simply having a prescription for medical aid in dying medication has an important palliative and comfort effect for dying people. And medical aid in dying laws do spur people to engage in in-depth conversations with their medical professionals. The end-of-life care options movement is growing strong. 9 states, Hawaii, California, Oregon, Washington, Montana, Colorado, Maine, Vermont, New Jersey, and then Washington, D.C. have all authorized medical aid in dying. So currently 1 in 5 Americans have access to this end-of-life option. Yeah. Well, the turquoise are the states that are authorized. It's a weird map. Blue states are where medical aid in dying was, where there was legislation last year. Some of the legislation carried over to this current legislative cycle, and that's getting going right now. We have a chance in New York. We have a chance in Maryland, but we work across the country. Mm-hmm. And then the yellow are states where we have actual volunteers on the ground.
Question.
Yeah.
Do you have to go through all of the process just to get the prescription, or is that process only for getting the drug itself?
Repeat the question.
Yeah, I'm not sure if I understand.
Do you need to have, for example, 2 before you can get a prescription, or are all those rules only to actually get the cocktail?
Well, what I'm hearing, I'm still trying to figure it out. The prescription and the cocktail, they're the same thing.
All the same. I see.
Yeah, it's just, people say it's a cocktail because it's a combination of medicines. So in order to get the medication, you do have to go through the process of meeting with two doctors, the attending and the consulting. You have to wait 15 days between each meeting with them, and then the written request. So in order to qualify for the medication, you do have to go through that process. Does that answer your question?
Well, I think so. So you're saying the prescription is no different from getting the cocktail?
Correct. Yes. I think it's just semantics, maybe. Cocktail sounds cooler. I don't know. Okay, so there, like we heard in Ralph's experience with his wife, Sue, and like the slide I have coming up, there are barriers to the law, and it's just the individual people, the physicians, the hospices, hospital systems, and the pharmacies are barriers. So this is a picture of Chris and Amanda on their wedding day last February. They were supposed to get married in December, but bumped it up when Chris was diagnosed with a rare terminal form of bladder cancer. He did everything he could to live, but after his bladder ruptured and it became clear he was not going to survive, he decided he wanted the compassionate option of medical aid in dying. He had watched his grandmother die of the same bladder cancer just 2 years earlier. She had had an agonizing death, and he did not want to experience that, so he asked his doctors for medical aid in dying. Chris was at a religious hospital, and his doctors were not allowed to practice the full range of end-of-life options. They did refer him to a hospice that they believe supported patients in the options of medical aid in dying. So he enrolled in the Southern California hospice, but they told him after he enrolled and had limited time left that medical aid in dying was illegal in Southern California, and he would have to transfer to Northern California, which is completely untrue. It's authorized across the entire state. Chris was in tremendous pain and could not transfer to another facility. He ended up having the exact death he did not want. He was robbed of his life and barred from having the end-of-life experience he preferred. On the right is a picture of Chris just a few months after his wedding. He suffered tremendous pain. His wife, Amanda, is furious he was not able to have the option of medical aid in dying. She took these pictures and asked us to share his story so no one else would have to go through what Chris did. So what Amanda and Chris went through and what other people go through shows why it's so important for us to continue our access campaign in California, because we need to make sure that all Californians have access to this end-of-life options if they qualify. So I do get a lot of questions about dementia and the End-of-Life Option Act. So if you're not mentally competent, you do not qualify for the End-of-Life Option Act. We do recognize that severe dementia is a difficult issue facing many older adults, and we're committed to improving the dying process for people with Alzheimer's and dementia. Our newly released dementia tools are online tools to help you or a loved one navigate treatment and plan for care following a dementia diagnosis. Our Dementia Values and Priorities tool is designed to be completed in advance of dementia or in its very early stages, when a person is still able to make their own decisions. So through a series of questions, a person can identify and document the point at which they would want to take advantage of existing legal options to refuse medical treatments or voluntarily stop eating and drinking while still receiving comfort care to prevent pain and suffering. In the end, you can then print out a customized addendum to your advance directive and specific and legally enforceable instructions for your healthcare proxy. So you can go on there and say, if I no longer recognize my loved ones, I want to stop eating and drinking, but please keep me comfortable. Or if I have a heart attack, do not resuscitate me. Don't bring me back. Or, maybe don't give me antibiotics. Those kinds of things you can, it's very detailed.
But you can request a aid and die.
You cannot request that. Mm-hmm.
It's a big but.
Yes.
Let's emphasize the but part.
The Dementia Decoder provides users with specific questions to ask healthcare providers to ensure that people living with or caring for someone with dementia obtain care consistent with their values and priorities specified by the patient or caregiver. So this tool allows either the patient or the caregiver to indicate the status of their dementia diagnosis, note what they're hoping to learn and accomplish from a clinical appointment, and customize a list of helpful questions. You'll find other content covering the span of dementia patients' experience on our website. You can just go to Compassion and Choices and you'll see it there. It does provide comprehensive planning and care resources to assist dementia patients, their loved ones, and caregivers. I think we're getting close to being done. Here's what you can do to be proactive now. Talk to your doctor and your family and tell them the option of medical aid in dying is important to you, even if you're not terminally ill. If you wait to talk to your doctor until it might be too late, and you don't want to be in the position of having to reestablish care with a new healthcare team. And then also go to compassionandchoices.org and check out the dementia tools, and do the dementia values and priorities tool, print it out and add it to your advance directive, and share it with your healthcare proxy. All right, so really quickly we'll get through. Here's our website, compassionandchoices.org. And then you may have heard about this before. This is our end-of-life decisions guide and toolkit. If you don't have an advance directive or if you want to update it, I do have fulfillment cards, and this will kind of walk you through that process. It also has information about assisted living facility riders and a dementia provision in there. So our doc-to-doc consultation service, which Ralph did mention, if you go to your doctor and your doctor doesn't have much information about the End-of-Life Option Act, you can ask them to call this toll-free number, and they leave a message. Within 24 hours, they'll get a call back from a doctor who has prescribed medical aid in dying and can educate them on the process. I think I brought some little cards, and I can put them on the table afterwards. We also have this Find Care tool, which is on the Compassion and Choices website, and you can go to it to find hospitals and hospices in your area that have supportive policies of medical aid in dying.
I take it even further. My wife had ALS. For the last 5 months of her life, she could not talk or communicate. She could not hold anything. She could not take, under any of these circumstances, the medicine. The only option that seemed available is when we went on hospice. Hospice brings a little brown bag full of morphine, or jars of morphine. And it may be possible for the family to utilize that morphine in a very considerable manner, which may lead to death.
Mm-hmm. Yeah, and I mean, palliative sedation is another option to end their life. But I lost my train of thought. So I did ask this of our doctor who runs our doc-to-doc line, and I said, because I get these questions about why not just take a bunch of morphine, and my understanding, he said that, people that are this sick, they have so many drugs in their body, they have a lot of morphine. For you and I, if we took that amount of morphine, it would definitely kill us. For somebody who has such a high tolerance for it, it may just put them to sleep for an hour or two. That's what I heard from him. So, it may not work. I don't know.
My only point is that there are certain restraints in the law which are I understand why,
Yeah.
but it doesn't always work.
Yeah.
There are a lot of roadblocks for accessing the law, not just the information, but there's people who can't even access it, and it's really unfortunate, but that's the way it is.
My question was about the advance directive, the supplement that you referred to, and I know the advance directive has to be either notarized or signed by 2 witnesses. I think one of them not related, but when you do a supplement to it, does that require redoing the whole advance directive and re-witnessing it, or?
My understanding, so if you do an addendum to your advance directive, do you have to get it notarized? I would have to go back and look, I'm not sure, but I don't think so. Yeah, you have a question? Yeah.
There are a number of European countries that have end-of-life choices that are far less difficult to negotiate than what we have passed in California. Is there any work being done by your committee to maybe modify the law to make it a little less of a barrier?
So in other countries, so he's asking about other countries that have less barriers to ending their lives. In other countries, you don't have to be terminally ill. You could be mentally ill. They have a lot less restrictions that we do in the United States. And euthanasia is illegal in the U.S., so we do not support that. Compassion and Choices does not support that at this time. So right now, it's more about trying to educate people about the law, educating medical professionals, just about the current law that we have. Yeah. There's one question back here.
My understanding of how the process played out was that the permanently disabled, the quadriplegics, paraplegics, etc., and also Alzheimer's sufferers were sacrificed in order to get something through for somebody. And I hear a lot of questions coming up about, hey, are you guys working on a next step? And it sounds like maybe you're trying to make the first step really be put into place right now is the focus. But I'll just mention that there are people who take matters into their own hands, and the information is out there, and an organization that's trying to stay within the system can't push that process.
Thank you for sharing that. Yeah.
So if you have other questions, why don't you do it after? I see over time so just come and they will answer any questions you have. The others that don't have questions, if they need to go, you can go. Thank you for coming.
Thank you.